Rochester, and technology is always a challenge sometime when one is trying to keep a tight timeline. But it's my great pleasure to welcome Dr. Dawn Demeo to be with us this afternoon. She is going to be our speaker for our 7th annual National Emphysema Foundation Visiting Professorship at Yale. I'd first like, before introducing Dr. Demeo, to mention a little bit about this visiting professorship. This is a visiting professorship in honor of Dr. Sreedhar Nair, who was a distinguished pulmonary and critical care physician at Norwalk Hospital in Norwalk, Connecticut, and a clinical professor of medicine at Yale Medical School. In the 1970s, he established the National Emphysema Foundation to fund research in lung disease with a special focus on obstructive lung disease. Over the past 40 years, the National Emphysema Foundation has funded research at multiple institutions throughout the United States and in India and the Philippines. Dr. Nair and the National Emphysema Foundation have generously supported multiple research studies and educational programs at Yale School of Medicine, including donations to our Yale COPD program. On his death in 2014, Dr. Nair's family and the National Emphysema Foundation endowed a visiting professorship at Yale in his honor. And it is with that we invite Dr. Dawn Demeo and welcome her to give this year's professorship lecture. Dr. Demeo received her undergraduate degree with honors from Yale University in biology. She then graduated AOA from Cornell Medical School in New York City and was the recipient of Coriell and Polk Prizes in medicine. She then received her master's in public health at the Harvard School of Public Health, did her internship and residency in internal medicine at Brigham and Women's in Boston, and went on to do her both clinical fellowship and a research fellowship in respiratory genetics at Brigham and Women. She joined the faculty of Harvard Medical School in 2002 and is an associate professor of medicine at the Harvard Medical School in the Department of Medicine. She also is an affiliate scientist at the Harvard School of Public Health. Her area of interest and expertise is in the genetics and epigenetics of lung disease, with a particular focus of interest on sex differences in COPD. And she has been actively involved in many committees, educational activities, working groups at Harvard, as well as nationally and internationally in societies such as the ATS and the NIH. She has served as a member of the Medical and Scientific Advisory Council of the Alpha One Foundation and serves as part of the COPD Gene Group, and most recently on the COVID-19 Death Adjudication Committee of COPD Gene. She's the recipient of many prizes and awards, including in 2019, a research award from the Alpha One Foundation, the Ignite Award from Brigham and Women's in Approaches to Sex Differences in Lung Disease, and she's a nominee for the Harvard Medical School Faculty Mentoring Award. She has extensive grant funding from NIH, the Alpha One Foundation, American Heart Association, and others for her research. She is the current site PI for studies on genetic epidemiology of COPD at Brigham and Women's. She has participated in innumerable teaching activities at Harvard School of Public Health and Brigham and Women's, both for research trainees and for clinical trainees in pulmonary critical care medicine. She's widely sought after for speaking engagements and lectureships nationally and internationally, and she has published her work widely in such distinguished journals as the American Journal of Respiratory and Critical Care Medicine, CHEST, New England Journal of Medicine, European Respiratory Journal, Thorax, Nature Genetics, Nature Medicine, Nature Communications, and many others. It is therefore a tremendous honor and pleasure to welcome Dr. Demeo to give the Dr. Sreedhar Nair Memorial Lectureship. And today her presentation is entitled Emerging Concepts in Precision Medicine, Sex, gender, and lung disease. Welcome, Dr. Demeo.
Thank you very much, Dr. Rochester, and I'd like to thank the organizers, Dr. Kaminsky and Dr. Mathey, and especially the Nair family for providing this opportunity to share my thoughts on precision medicine through this professorship. And it's really wonderful to Zoom into New Haven today. As mentioned, I was a Yale undergraduate, and my research career started 30 years ago here at Yale when I was an undergraduate and working in the orthopedics laboratory of Dr. Mark Horowitz on a project about bone allograft rejection. And this was my first exposure to basic science. And from Dr. Horowitz, I was taught enduring lessons about hypothesis generation, careful experimentation, documenting research, reproducibility, and as well as about mentoring. And these were really seminal and transformative lessons that profoundly impacted my career trajectory towards academic medicine, and that I've taken with me through my journey where we start today. So I like to think of the trek towards precision medicine as one that starts in utero. And although we can't address all of the facets of what we've been studying with regard to sex and gender, it really behooves us as pulmonologists to remember that a lot of pulmonary diseases likely have fetal origins. And as we think about this trek, I really want to set the stage for these objectives, to provide an overview of the associations we see with sex, gender, and COPD, to propose a role for systems biology to integrate sex and gender differences in understanding COPD progression, but really to convince clinicians and researchers alike that the path to precision pulmonary diagnostics and therapeutics really lives in the science that captures sex and gender-related causes and effects. And the limited attention to sex and gender issues really drives the perpetuation of health disparities between women and men, and highlights the need to address sex and gender differences as key drivers of health and disease. If we look at the national vital statistics, we see in comparison of males and females that heart disease and cancer are predominant causes of death in men. But when we get to the third cause, chronic lower respiratory disease, we see that women predominate in terms of cause of death. Any discussion about sex and gender really makes sure we know what the nosology here. When we talk about sex, we're talking about issues related to biology, genetics, hormones, other biologic influences, airway anatomy, whereas gender partake in more of an environmental construct, lifestyle, behaviors, smoking, occupational exposures, and then the more complicated issues of gender identity and identification that we're not going to have time to touch on today, but really are crucial as we know that gender minorities make up a large proportion of chronic disease. If we think in terms of sex differences, we know sex differences are recognized as one of the most significantly understudied aspects of human disease research. Many prior experimental studies, both animal models and humans, don't include equal number of males and females. Sex chromosomes have been categorically excluded from many genomic analyses, and sequence mapping protocols have not accounted for sex chromosome biases. So it's really in this context that we need to understand and account for biologic sex differences as well as gender-related issues if we want to improve prevention and therapeutics. Any conversation about sex differences in lung disease harkens back to observations related to smoking. And for this, I really turn to the US Surgeon General reports for my history. In 1964, if we look at the first Surgeon General's reports, women were suggested not susceptible to the effects of smoking. By 1980, we see a recantation of this in the Fallacies of Women Immunity publication, where the smoking effects on women were suggested to be likely more prominent in the coming decades. And by 2001, we see a Surgeon General's report on women and smoking, where it's suggested that gender differences may exist related to genetic polymorphisms. And this was a really important element for me to read, and it fueled my first grant in sex and gender differences around this time, and my participation in writing for the 50 Years of Progress report on women and COPD. There are many reviews on tobacco, and this is not a specific lecture about tobacco, but just to note, there have been large reviews of the literature that have determined that beyond age 45 to 50, female current smokers have significantly faster annual lung function decline. We also know that upon smoking cessation, women may experience a more dramatic improvement in lung function. And we're not going to focus on tobacco, but COPD, but they're intimately related in the Western world, as many know. So if we think about the prevalence data, there's been a lot of controversy in the literature of whether males or females have higher prevalence of COPD. If we look at some of the older studies, pool prevalence analysis reported that COPD was much more prevalent in men at about 10% versus women. In the BOLD study, an off-cited study, COPD prevalence was suggested to be equal between men and women. But a decade-old study now from the CDC observed if you parse by age group, we see that the prevalence of COPD predominated amongst women. Perhaps even more visionary was this report publishing COPD prevalence details by income and sex. If we look at the curves with income on the x-axis, we know that poor women are disproportionately represented amongst chronic disease. And even when we consider this, we still see that women predominate. So the intersection of disparities we may observe in medicine for lung disease may be intimately tied to socioeconomics. This observation of global prevalence varying by sex is also present. So we can find, if we look more broadly outside of the US, we look at Sydney, Australia, we see that the prevalence rates of COPD in women surpass those in men, and that we really need to think about the global trends to recognize each country has slightly different sex-specific considerations, but there's no question that we see sex-specific differences. One of the most profound moments I had in the early 2000s was reading this MMWR. So if we look at year on the x-axis and the number of deaths on the y-axis, in the year 2000, the number of women dying from COPD surpassed the number of men. And this was the first time this ominous trend was observed. And the projected increase in COPD morbidity and mortality was projected to be due to COPD in women. By 2017, we see this report in JAMA, which suggested that the overall 30% increase in respiratory mortality was related to COPD mortality, with the highest mortality in Central Appalachia, again, links to socioeconomics. But although the COPD mortality rates reported in this JAMA article were noted to be decreasing, the rates of mortality in women increased more than 100%. So why is this? What is driving this? I think for many of us, we're very tuned into thinking about COPD, but if you look in the literature, there has been a repeated suggestion of a bias in diagnosing COPD in women. This is a really fantastic study from Chapman's group, who took a hypothetical patient presenting to a clinic, gave this to 192 PCPs as a case report. It was a report of an ex-smoker with 40 pack years, chronic cough, exertional dyspnea, expiratory wheezes, varied the gender and the ages. Women were less likely to receive the correct diagnosis as COPD compared to men, and they were more likely to be diagnosed with asthma. And this type of study was repeated by Mark Mirabiti's group in Europe, suggesting this wasn't just a US bias. So we really need to be in tune to thinking about chronic obstructive pulmonary disease in women, because underdiagnosis is part of the clinical concern. We also have concerns about suboptimal therapeutics, which is part of what fuels my research interests. We know that women present slightly differently. They tend to be younger and have smoked less. They have more symptomatology. And in addition to this, with COPD presentation in women, we tend to see more comorbidities such as osteoporosis, anxiety, depression, and this sensitivity to these differences in presentation need to rise to the level of awareness as our colleagues in cardiovascular disease have been able to achieve for heart disease. We think in terms of risk factors for sex differences in COPD. We see environmental exposures. I think it's important here to make the point, if we look globally, that women predominate among the individuals with COPD and never having smoked. And so this really suggests to some underlying predisposition. We come down here to genetic factors, and although genetic factors have been linked to COPD in both sexes, women have been described to have genetic predispositions to severe early onset COPD. And when I first got to the Channing, Ed Silverman had published this report of gender-related differences in severe early onset COPD. He described a population of women and men with COPD at the age of onset less than 53, and noticed that all phases of enrollment of the study, women predominated in representing the group of COPD patients less than age 53. This is a really unique group. This is the group we see in the lung transplantation clinic. So age of onset really may drive novel insights into understanding some of the pathogenesis of sex differences, as well as COPD in general. We were able to replicate this finding. Marilyn Foreman, who is a former postdoc of mine, published this study and was able to observe in the COPD gene study, if we parse COPD gene participants, this is about 10,000 participants, if we parse by age group, what we observed again was the predominance of early onset COPD in women. We also saw this interesting peak in females compared to males at the other extreme of life, suggesting that modeling the life course approach isn't only necessary to understand early origins of COPD, but the intimate relationship between gender differences and aging. We thought about what could be driving this female predominance of early onset COPD. Well, women have smaller lungs, so maybe that's part of the story. Maybe there are competing causes of differential survival in men with COPD. Maybe we're dealing with an X-linked dominant. And again, I can't talk about everything we're studying, but we're getting ready to publish on this concept. Hormonal issues, differential reporting of tobacco, secular trends related to smoking. And more recently, I think as we look ahead, this is going to be related to vaping and cannabis inhalation. But really, we're landing here that there is truly some differential or increased female susceptibility, perhaps by gene by sex interactions. As a side note, this is a really important literature for pulmonologists to be aware of. Menopause is associated with accelerating lung function decline. And I think this is a really nice example of how research intersects with clinical medicine, because we really need to be aware as clinicians that respiratory health often deteriorates during reproductive aging. And although this is about menopause, we need to be aware that andropause, the age-related drops in testosterone, can also be associated with changes in lung function. We took this concept of a life course and aging to heart, and we looked again in COPD gene, parsed by age. What we observed was that regardless of age, women again present with more shortness of breath, dyspnea, more exacerbation, and that dyspnea and exacerbation really seem to be symptomologic aspects we can study to further understand the biology potentially driving sex differences. So I've thought a lot in the last 2 decades about how to really interrogate the genome to answer some of the science that may be driving these differences between men and women with advanced lung disease. This is a fantastic article that really suggests we need to consider endogenous and exogenous factors and how they interact with the genome, and that it may not be genetic variation alone, but gene regulatory events related to the epigenome, as well as ways in which genetic variation impacts gene expression that may be of consideration. We know that sex-specific genetic architecture has been described for a host of traits, including lung function, and that as we repeatedly fail to model sex-specific architecture, we're really missing a lot of the susceptibility of disease. And this isn't just studying of the autosomes, but the sex chromosomes. Throwing out X and Y has really been standard. And this is just a reminder to say again that in this assessment of X chromosome studies, not a single one of the studies to date has been on the X chromosome and COPD, but we'll change that. So as we were thinking about how to best capture sex differences, gender differences in the biology, I really returned to this important article by Fernando Martinez and group. And it's an old one, but I think it really sets the stage. What they did in the National Emphysema Treatment Trial was look at CAT scans, quality of life data. And they too had observed that women with COPD reported more dyspnea. When they looked at the CAT scans, they noted that there was less overall emphysema, especially in the periphery of the lung. And on histology, women tended to have thicker airways and smaller airway lumens. And this raised this nagging specter, is emphysema a phenotype of men? And is emphysema a key trait that we should study with regard to sex differences? So we started out trying to interrogate sex-specific architecture by first looking at COPD. And this is an article published by one of my former postdocs, Megan Harden. And what she did is looked at emphysema phenotypes in COPD gene in non-Hispanic whites and African Americans. And what we did is we looked at all subjects, individuals, early onset disease, severe emphysema, and advanced gold grade 4 COPD. And here we have on the y-axis emphysema. When we looked at all subjects and we compared men on the left and women on the right, men seemed to be having more emphysema, higher percent low attenuation areas on CAT scan. But when we looked across the different subgroups, women had just as much emphysema as men. So although there may be some dimorphic features of what we see clinically, it does seem that emphysema is not a phenotype of men, but maybe how we get there biologically may be different. So we studied in our first genome-wide association study to try to drill down on sex-specific genetic architecture of COPD and COPD subphenotypes. When we looked at our genome-wide studies, we parsed our study by sex, females on the left, males on the right. This is a regional association plot. So this is a stretch across chromosome 22. It's the same region on both sides. And what we saw is when we tried to link genetic variation to our phenotype, COPD in this case, we saw a peak in the SELSR1 gene here, which was not present in males. And we were very excited about this because although we didn't meet strict genome-wide testing thresholds, we saw a pretty robust signal that replicated. And we got lucky here because SELSR1 is a key gene involved in normal branching morphogenesis, an early stage of lung development that has links to airflow limitation later in life. So we've been preparing to follow up this finding, but this is one way in which we can interrogate sex-specific genetic architecture. But I think this article published in the Biology of Sex Differences puts it out there pretty plainly. From a genetic point of view, this is a paradox. Since men and women share the vast majority of genetic sequence variants, how can males and females differ in these ways yet have a common genetic code? So this question has noodled at me for quite some time, and it led me to explore epigenetics. So epigenetics are defined broadly as the non-sequence-based variations that can impact gene regulation. More broadly, they can be considered any causal mechanism that can act on genes to impact phenotype. A lot of people put DNA methylation in this category, but of course, other features like microRNA and some of the other variable epigenetic marks fall into this category, but lots of people are studying DNA methylation right now because we can assay it in archival DNA. So Emily Wan, one of my former postdocs, did this beautiful study where she looked at cigarette smoking and differential methylation, first not stratified by sex. And when we compared the DNA methylation of current smokers versus former smokers, we saw several genes that rose to a genome-wide threshold, including CYP1B1. Now, CYP1B1 is an interesting gene because it's a xenobiotic metabolizing gene, so a key gene that deals with metabolism of cigarette smoke. We then carried this forward to look at association of differential methylation at this site in the CYP1B1 gene with lung function and percent emphysema. And we saw a very sexually divergent association for differential methylation at this site and association with women in these phenotypes, but not men, suggesting that one of the driver of differences in phenotypes we see related to COPD may be related to gene regulation and not necessarily living only in sequence variation. And intuitively, this started to make more sense. Other groups have come at this by looking at other big data. Proteomics is one example. So this group has looked at a comparison of female smokers with and without COPD and male smokers, and have identified different proteomic signatures that seem to associate in the sexes differentially. So as we start with basic omics, like genetic variation, and scale up to metabolomics, proteomics, pick your omic, we really need to be mining these data in a sex-aware fashion. So this really leads us to what we're really excited about now, and this is network medicine. So as noted, my prime appointment is in the Channing Division of Network Medicine, so we spend a lot of time thinking about and developing mathematical algorithms to mine big data. And we put it in a network framework. So what is a network? So simply stated, a network is just a collection of points, which we call nodes, that are joined by a pair of lines, which are edges. And it allows us to visualize the complexity of the relationships between variables of interest. In our condition, these variables of interest are different omic factors. And the genesis of networks is really exciting because it leads us to this concept of network medicine. And network medicine being this broad study of cellular functioning disease to be able to quantify how factors are linked. And anyone who's really interested in networks should read some of the work by Laszlo Berbasi on this topic. But the key components of network medicine and the key drivers of how we think about lung disease in our division is that it's holistic rather than reductionistic. Instead of saying this single gene does this to cause COPD, we're really looking at how these signatures are interconnected. And it allows us to develop these molecular networks. Perhaps more importantly, for a disease like COPD that does have such strong environmental influences, we can capture nonlinear responses and the complexity of these nonlinear responses. We're not bound by just modeling linear effects. And we really focus on ways to employ systems-based approaches to mine the data to develop these networks for men and women with and without lung disease. So we started this work in a systems framework about 6 years ago. And this is work I've done in collaboration with John Quackenbush and Kimby Glass, who we continue to collaborate with in this realm. And what we've been able to do is develop a framework to evaluate big omic data in a sex-specific context to develop networks. So we did this for COPD, and one of the exciting outcomes was our finding that perhaps mitochondrial pathways may be a key pathway driving differences in chronic obstructive pulmonary disease in men and women. And any network scientist will invariably show what we call a hairball of nodes and edges. And so these are the hairballs of sex-specific differences in COPD. We have a sputum network on the left, a blood network on the right, female-specific edges in pink and male-specific edges in blue. And instead of digging in on the details, I think at a high level, what we can appreciate is in the sputum network, we have a lot more edges in women versus men, and that these edges are targeting between different transcription factors and different genes in men versus women. And this is really the first time that we've been able to get to this systems framework in ways in which to think it's not necessarily a specific variant, but perhaps it's how genes are targeted that matter. And so what we noticed, and we've noticed this again and again, if you compare men and women, there are not a lot of sex differences in gene expression, but there are a tremendous number of differences in gene regulation. And this is an observation that we've now carried forward into the GTEx consortium data. And this is in press, it should come out next week, where we scaled this up and said, well, what about other systems? Does what we observed in the lung scale up to other organ systems? So in this, using this paradigm of developing sex-specific networks, we were able to mine the data of 548 individuals across 29 tissues, including lung, and develop over 8,000 individual networks. And again, we saw the same pattern by tissue, including lung. There were no profound differences in gene expression, but very profound differences across every organ system by sex and how genes were targeted. And so we really believe for lung disease and diseases writ large that we see in the clinic, that if we're really going to be able to make an impact in precision medicine and therapeutics, we need to think in terms of how to mine differences in gene regulation. So this has therapeutic implications, at least how I think about it. We know, again, taking it back to the clinic, that COPD studies have not generally been powered to detect sex differences. We know in some of the early studies, inhaled steroid use was a predictor of reduced phlegm production in men, not women. But I said at the beginning of the talk, we know that women have thicker airways. They likely have more chronic bronchitis with increased sputum production. Those are the phenotypes that many female patients come with. But a lot of these studies that look at sex differences kind of contradict our expectation. And partially it's because they're not powered to look at sex differences. If we think about some of the studies we all learn about as fellows, TORCH, for example, a study of salmeterol plus fluticasone and placebo. If we think about all the outcomes related to TORCH, the combination regimen reduced exacerbations, improved health status, was associated with improved spirometry, but this cohort was 75% male. So how do we really justifiably extrapolate these therapeutic observations to females and feel like this is a powered way to dig into the therapeutic literature? I'm happy to say that this is starting to change. We're now starting to see different studies emerge from the COPD therapeutic literature that specifically addresses sex differences. There's been this study on indacaterol and another study on ipratropium that specifically ask a priori, are there sex differences in these clinical responses? So as we think about the science, the science of systems biology and network medicine is complicated, but at the end of the day, we're clinicians. We bring this back to what we see in the clinic, what we observe, and what we need to be mindful of as we develop these mathematical models. We know that women carry the excess burden of COPD in terms of age of onset. They're younger with advanced disease. They have more symptomatology, shortness of breath. They have greater healthcare utilization with more frequent exacerbations, hospitalizations, and disparities in death rates. We have made therapeutic observations where women may have increased susceptibility to tobacco smoke. They're overrepresented in groups with treatable traits, but perhaps we don't know the best therapeutics. We know that smoking cessation may be more impactful in terms of improvement in lung function in women, but we also know these approaches need to be personalized. Women have more comorbidities. So all of these together really behoove us to have a sex-specific consideration as we try to drill down on the molecular targets. So what is the clinical agenda I see from this science? Well, we need to suspect COPD in women to get away from the biases. We need to treat nicotine dependent in a sex-aware fashion. We need to address all these different interventions, including differential responses women may have with pulmonary rehab. We need to provide clinical care with attention to sex and gender, as well as issues related to gender identity. We need to set this dialogue for a partnership in women's health. We need to intervene with education at the earliest levels to impact the vaping epidemic in our young teenage girls. We need to engage in social media. We need to really think about sex-specific public health messaging for preventive care. And we really need to partner from research to legislation to really make sure precision medicine in a sex-specific fashion gets on the map as an important, viable endpoint and deliverable of research and clinical care. So we know historically women were excluded from clinical trials, and this was under the belief partially that men and women would not differ in their response to therapy. There have been reports that are really important to read for anyone interested in gender medicine that suggest that we need to include women because they introduce new variables and We need to really be more systematic about how we think about starting clinical trials to be sure we're powered to address sex differences. In 1993, we saw passed the National Institutes of Health Revitalization Act, which provided guidelines for the inclusion of women in studies. But how are we doing as a pulmonary field in terms of the literature? I think this is a really important paper that looked at sex and gender specific research. If we look at year on the x-axis and number of publications on the y-axis, we've seen this progressive increase in the literature related to publication trends. But if we look at our field of pulmonary medicine, we perform worse in terms of research and literature published to understand the pathophysiology of sex differences in lung disease. We're still behind the cardiologists, but we're far behind a lot of other fields as well. So I think this really should spur us forth as a clinical investigative group to rectify this trend. So what do we do to set a research agenda? And this research agenda is not only to understand the disease, but to inform clinical care. For my own work, I feel this agenda is inherently multidisciplinary and collaborative. We need to address sex and the harder to measure gender, and gender capturing the environmental constructs as well as issues related to gender identity. We need to be inclusive of animal models to be able to look at sex-specific effects in murine modeling. And we need to be able to harness trials to not only detect sex differences, but understand the pharmacoepigenetics and pharmacogenetics that may be driving this. And I feel that this really points us to a primary role for systems biology. So I feel that the next decade of research really is going to focus on big genomic data. The bigger, the better. That phenotypes and subphenotyping of sex differences is really key as we take these multi-omic approaches to large biobank data to bring systems approaches into the models. We have as a goal to develop sex-specific or at least sex-aware therapeutic interventions for COPD. And what I'm working on right now is trying to understand better how to capture gender in the pulmonary clinic. Sex we capture in the research by looking at chromosomal complement, but how do we better improve our ability to do this clinical research? And I think what we really need to do as a pulmonary group is move away from reactive medicine to P4 medicine, which focuses on prediction, participation, prevention, and personalization. But we can't personalize if we don't start at separating out the men from the women, at least for some domains. So I want to thank you for your attention. I really want to point to my mentors, starting with Mark, who was one of the earliest individuals to engage me in science and the importance of academic research. I learned a lot from John Samet throughout the years on the health effects of smoking and participated in multiple Surgeon General reports. Steve Shapiro taught me a lot about murine modeling. Augustine Choi is an ongoing collaborator in trying to understand links between IPF and COPD. Scott Weiss has been a mentor for my studies on asthma and fetal origins of adult disease. And of course, my longtime mentor, Ed Silverman, who's the chief of the division in network medicine at the Channing, who's worked with me at all aspects on COPD genetics and supports my work in epigenetics. And I'd like to acknowledge my funders. And there I'd like to pause and take any questions.
Thank you very, very much, Dr. Demeo, for that terrific lecture. It's a very inspiring topic, very interesting, and gives us much more work to do all collectively as we go forward into the future. I'd like to open up the discussion for questions. If people do have questions, please post them onto the chat and I will read it out loud. Any questions for Dr. Demeo? I'll start with one. Do you think that in order to get at, to further delve into the different phenotypes, if you will, even on a simple level such as emphysema predominant versus inflammatory airways disease predominant and other sort of subgroups frequent exacerbators, non-frequent exacerbators, et cetera. Do you think that we are at all at a point where we could begin to dissect out sex-related differences in those, or do you think we need to start with a much broader look at the network, such as you mentioned, and then drill down further from there?
I think that's a fantastic question. I do think we feel pretty convinced at this point that we understand that these networks in baseline normal tissue are likely different between men and women. I mean, we've done a lot of analysis on presumably non-disease tissues. You know, the source of the tissue, of course, is always a limitation when you're talking about being able to study normal. But we do believe that genes are differentially targeted between men and women without disease. And so scaling this up to disease and scaling this further to look at subphenotypes, that's the direction of the work we're doing. And I think this is a way in which using exquisite phenotyping from studies like COPD gene, where we have high resolution CAT scans on 10,000 people, and we can really use machine learning and other kind of artificial intelligence type deep learning approaches to mine the phenotypes. We can kind of start with a combined approach, developing molecular phenotypes that may be different, but also actual phenotypes. So that's really the direction that our work is going now, in addressing not only COPD as a binary phenotype, but then some of the more quantitative aspects, lung function, emphysema, and issues such as those.
Great. We have a couple of questions from our audience. One is from Dr. Kaminsky on a related note to what you were just talking about, is how do you move from networks to interventions?
So what we are starting to do is take our network findings, and this can be sex differences, this could be any difference, and mine them against these databases of small molecules, identify small molecules that may be isolated by these differential edges, and then take those back to the lab and test those in organoid systems or cellular models. So again, there's a lot of recursive treks between the bench and the bedside and back, where we need to develop the right kind of models. But this, you know, like I said, we find the network edges that are different, isolate the genes, and then start looking into in silico ways to identify novel targeting therapeutics.
Great. And I believe this is from Dr. Soller, if I'm interpreting the numbers correctly here. The question is, do sex differences have a greater role in COPD related to early life events versus COPD related to rapid lung decline?
Yeah, that's a great question, and I would honestly say we don't know, but what we've looked at, we have a really unique opportunity where we have access to a set of fetal lungs from the pseudoglandular and canulicular stages of in utero development, and these lungs have been differentially exposed to cigarette smoke, and we do see sex-specific differences in association with cigarette smoke exposure during lung development. So what I believe is that some of these issues are going to be related to sex differences in reaching maximally attained lung function related to in utero exposures. We also know that other prenatal exposures such as vitamin D, as well as potential other nutritional factors during lung development may recapitulate later in life. I think your question about what's more important, those early life events and perhaps not reaching maximally attained lung function versus accelerated decline, I think that's what we're trying to sort out with some of our life course models, where we start in utero and end at the extremes of life. So I can't answer you honestly yet, but maybe next year.
Great. And a related question, how do sex differences in gene regulation change over the lifespan?
So again, this is a place where we're doing the modeling now, where we have a large enough data set of adult lung tissues and we have our fetal lung set. So we're still developing those network models. So I can't point to specific genes or pathways as of yet, but what we do know is if we just think in terms of what happens in lung disease during puberty, we know for asthma, for example, that we see flip-flops in asthma prevalence between boys and girls at that pubertal transition. So we do believe that some of that is going to be related to gene regulation related to hormonal factors. So from a life course approach, we really need to study all these places in the life course that may give us further information about how these transitions are occurring.
Great. Dr. Atkin is wondering, in addition to the DWAS approaches to improve lung health for women, she's wondering about health systems-based interventions to think about ways to improve COPD evaluation and management in non-specialty settings such as primary care, and whether you could comment on your thoughts on that.
Yeah, I mean, I think this is really an important issue because we all know as pulmonologists that many of the COPD affected individuals in the country are managed by primary care. And I think what this really bespeaks, it harkens back to the persistent biases related to diagnosing COPD in women. You know, we really want to start with the basics, reminding people, physicians in the community, to do spirometry and to consider doing spirometry in women and men, because it's still the case that women tend to receive less of the basic tests that we would normally reach for, spirometry, CAT scans. And so I think even before fancy molecular diagnostics, I'm really concerned that we need to be sure that women are getting spirometry and CAT scans as they need them. So I would start there. My hope is that down the line, that we'll be able to use epigenetic marks, for example, as a way to get to preclinical diagnoses in both men and women. I mean, I feel like that's still far off, but that's the hope of some of the research I'm working on now.
Great. And Dr. Koff wanted to also congratulate you on your talk as well. And he's mentioning in cystic fibrosis, there is evidence that young women have more severe disease compared to men. And that cigarette smoking activates CFTR dysfunction, and neutrophils have different sex-based responses in CF. He's posing the question, he wonders if this impacts COPD over time and contributes to the increased airway disease that has been reported in women.
Yeah, I think that's a fantastic point. And I can tell you, when I was doing transplant work, we were always very concerned when young women with CF started to decline, but because we knew that once the decline would begin, that it would be quite precipitous. And I do think that there's a complicated regulation going on related to hormone factors, potentially gene targeting of CFTR together with the inflammatory response. We have individuals in our group looking at CFTR in relation to COPD, but I myself haven't specifically looked at it, but I think that's a fantastic observation to follow up on, absolutely.
Great, and there's a couple more questions. Dr. Charles Delacruz also wanted to congratulate you on your talk and was wondering if you have any initial insights or comments on the effects of sex differences in COVID-19.
Yeah, I think this is a really important topic for pulmonologists. So one of the main genes that has been associated with COVID susceptibility is ACE2. And now everyone's excited about the X chromosome because ACE2 is on the X chromosome. And so I think, what we've been looking at is differential expression and targeting of ACE2, as well as some of the other genes that may be relevant to COVID-19. So obviously it's kind of too early to tell, but we do see differences related to gene expression and gene regulation in the lung tissue related to COVID-19. So again, this is all very preliminary and not published, but I do think as bigger data sets emerge, we will definitely be able to hone down on some of the genomic signatures that differ between men and women. related to COVID susceptibility. I think in terms of the COVID susceptibility, there may be other related factors, not necessarily related to these genes, but at least right now, that's what a lot of people are looking towards.
Great. And Dr. Kaminsky is also wondering, is there any information available about differences in different groups of women, for example, minority women or transgender women?
Yeah, this is a really important direction I've been trying to move in, because I think this is, from a health disparity standpoint, it's an important unmet need in the field of pulmonary medicine. And I think we know that gender minorities have higher rates of cigarette smoking. There's also exogenous hormone use, and potentially how some of these interact together and recapitulate on the genome has not really been effectively investigated. So this is a direction that I need to move in. And Dr. Kaminsky, any further input on this offline, I'm welcoming if you have any ideas.
Great. Wonderful. Are there any additional questions for Dr. Demeo? This has been a really exciting and interesting discussion. Your talk was wonderful. It's a tremendous tribute to Dr. Nair and his efforts on behalf of the field of COPD. We're all greatly appreciative, Dawn, of your being here with us today. This really represents not only a very exciting talk in an exciting area with much future research to be done and to move the field forward, but also it's our first return to grand rounds after a period of hiatus in the setting of the COVID crisis. And it feels good to all of us to be back thinking about topics such as this. And we really greatly appreciate your effort and your being with us here today. And Dr. Kaminsky and I and others would all like to thank you for your wonderful talk. I'm asked to remind everyone that this talk is available on our YouTube and Facebook channels. And if you wish more detail, you can check on Twitter at Yale PCCSM. Also, Debbie Lovejoy has posted the information as to how to receive CME credit on the Zoom webinar chat. So you can check on that if you wish to receive CME credit for your participation in today's webinar. Are there any other questions or comments? If not, then we would like to again congratulate you and thank you so very much, Dawn, for being with us here today. And I think we're all sending a big round of applause to you. Thank you very much, Dr. Demeo, and we look to see you again. Hopefully you can have you visit us in person in New Haven in the not too distant future, and hope to see you at various international conferences as well. And all of our messengers are sending you their messages for thanks for your wonderful talk.
Well, thank you so much for the invitation. It's a real pleasure to be here. Thank you.
Thank you again.
Yep, bye-bye.
Bye-bye.